with you today some thoughts about ultrasound imaging for advanced endometriosis. So here are my disclosures, none of which is related to the topics of today's talk. So I'd like to start with this image showing you a recent patient that we just did with a multifibroid uterus with adenomyosis, complete cul-de-sac obliteration, bilateral ovarian endometrioma, and the bowel was completely stuck to the back of the uterus, as you can see here. So this is a live video from the same patient. You see the sigmoid colon is sucked into the uterus. There is no pelvis that you could see posteriorly. These are the ureters with lighted stents. And doing a systematic examination, you could see that it's really frozen pelvis, and that is a patient that would require a lot of surgical planning as well as the involvement of general surgery, because in this case there was a bowel nodule that was not shavable and it requires resection, anastomosis of the colon. And I'll show you at the end the final outcome of this patient. Here's another patient with a partial cul-de-sac obliteration following a hysterectomy. As you can see here, this side of the pelvis is not obliterated. This is the ileum and this is a sigmoid. And if you progress away from that side wall and you go anteriorly, you see a nodule of endometriosis here with a sigmoid colon attached to the bladder as well as to the vaginal cuff, and it's also infiltrating into the lumen of the sigmoid colon and requiring a resection. And this patient has a prior surgery before there was surgical plane loss on the left side, which would also likely to require resection and anastomosis of the colon. Consequently, with all of that, it's quite imperative to ask this question: can we predict that preoperatively or during fertility treatment? These two patients that I have shown you would never get pregnant naturally, particularly the first one, because you could see that the tubes are buried underneath the colon, even if they are open. And also, the surgery itself will be quite complex. That would require multidisciplinary approach, and it's better to be done in a tertiary care facility. So that question could be answered simply by yes, and the yes is coming from the fact that if we do good planning by appropriate imaging, we'll be able to predict all of that. So here are my objectives for today: is to review a domain-based protocol for careful and detailed pelvic assessment that you could implement in your practice, and to make you familiar with the correct technique of the so-called dynamic ultrasonography or gel sonovaginography, and also to review the surgical and reproductive implications of a specific signs that we see routinely in these cases called the negative sliding sign. What it means if you find it either from the surgical planning perspective and from the fertility perspective, and also from obstetrics perspective, as I will share with you shortly. So that domain-based approach or protocol is composed of 5 domains. Each domain has features, and it also has types of endometriosis that you should look for in that domain. We have domain 1, 2, 3, 4, and 5. Domain 1 is what we all do, which is routine assessment of the uterus and ovaries. Domain 2, that is a learning point, and I want you to learn that. It's called tenderness guided assessment, which you focus the scanning on the areas that are tender with a transvaginal ultrasound. And domain 3 is another learning point, which is about organ mobility, which involves the mobility of the ovary as well as the uterus. Domain 4 is the assessment of deep infiltrating endometriosis outside the bowel. And domain 5 is assessing the anterior wall of the rectum and the sigmoid or bowel endometriosis. So let's start with domain 1. Domain 1 features includes both the uterus and the ovary. Commonest lesion that we find in the uterus in patients with advanced endometriosis is its twin sister, adenomyosis. And the commonest lesion that we find in the ovary is endometrioma. So these are the two types of endometriosis backslash adenomyosis that we see in domain 1. They should not be mistakable, and everyone should be able to find them and characterize them appropriately. Starting with adenomyosis pretty quickly, there are the most criteria that we are currently using. That includes echogenic subendometrial lines and buds, as you can see here, and hypoechoic islands that are small microcysts. And if you, the microcysts here and the hyperechogenic islands are here. And there is anechoic cysts between 1 to 6 millimeter that's under the endometrium. You can see them hysteroscopically, they're usually bluish. And if you cut through them, you'll find chocolate material coming into you. The hypoechoic fan-shaped linear striations, also called the rain in the forest sign. That is a patient with a recurrent pregnancy loss that we saw with typical linear striation specific for adenomyosis with a gestational sac here. A week later, this patient developed a big subchorionic hematoma and she ended up miscarrying. The other translesional sign is the vascularity, defined as vessels that are perpendicular to the endometrium, crossing the lesion itself. You can see here posterior wall adeno, and these are the translesional vascularity. And this is a live video from a patient with a thicker posterior myometrium, thinner anterior myometrium with translesional vascularity specific for adenomyosis. And that's to be differentiated from the circumlesion vascularity that we see in patients with uterine fibroid. One of the common mistakes in ultrasonography is mistakenly diagnosing adenomyosis as fibroids, which has consequences either clinically or surgically. There are two signs as it pertains to the junctional zone that could be irregular or interrupted, as you can see in these two images. Usually that is hard to detect by ultrasound, and sometimes you need an MRI to detect that. All of these changes can lead to globular enlargement of the uterus, as you can see here, or asymmetrical enlargement, which is much more common. And usually it's more thickness to the posterior wall of the uterus compared to the anterior wall. So in summary, there are 3 subendometrial signs, which includes the lines and buds, the echogenic islands, and the cysts. There are 2 translesional issues, the translesional vascularity and the fan-shaped striations. There are 2 signs related to the junctional zone, either irregular or interrupted. There are 2 signs related to the shape of the uterus, which includes both symmetrical or globular enlargement versus asymmetrical enlargement. So to remember this, 3, 2, 2, and 2. So another sign that should attract your attention to look more closely for adenomyosis is the so-called question mark sign that has been shown to predict adenomyosis with pretty decent specificity, sensitivity, and predictive values. The second lesion in domain 1 is endometrioma, and that speaks about itself. You can see it clearly. There's no excuse for missing endometrioma with the typical ground glass appearance. It's important to remember this. If you have an endometrioma with a high score of chronic pelvic pain using the visual analog score, there is close to 30 to 35% chance of finding concomitant deep infiltrating endometriosis. And if the pain is more severe or the score more than 7, it's up to 60% chance of finding deep infiltrating endometriosis. So if you see endometrioma, it's almost certain that in half of these patients, there is a deep infiltrating endometriosis that you should look for. And you should not be satisfied by removing the endometrioma only, particularly in a patient with chronic pelvic pain, and leaving the deep disease behind, because that would not cure or help with the pain, as the pain would persist after removing the endometrioma. That is domain one. Remember, adenomyosis and endometriomas. When it comes to domain two, the main feature, it's a site-specific tenderness. Imagine the transvaginal probe as your finger during the bimanual examination. You're pressing and you're seeing the tender points by your fingers when you examine. But when you use a transvaginal probe, you can elicit tenderness, but you can also see on the screen at the time of eliciting that tenderness transvaginally. If there is a tender point with a transvaginal, just be gentle first, don't cause more pain for the patient, and then look at your screen. Most likely you will find some nodule somewhere. The commonest two sites that you find nodules are the atrosacral ligaments, as you can see here, or the torus uterus, and the vaginal wall itself. This is gel distending the upper part of the vagina, and this is a posterior vernix, and you can see the focal thickening of the posterior vaginal wall here, with a nodule that may require partial vaginectomy as part of a good laparoscopic surgery to remove the disease. That is domain two. Domain two is tender-specific scanning. Domain three is organ mobility assessment, and again, that has two components: the ovarian mobility to check for ovarian adhesions, and the real-time dynamic sliding sign, which detects partial or complete obliteration of the pouch of Douglas. And I will spend more time on that domain because it is important, and it's important to learn, and that's the third learning point today. So why it is important to protect the pouch of Douglas obliteration? There are two major implications for that: a surgical one and a reproductive or fertility related one. The surgical one is that women with pouch of Douglas obliteration at laparoscopy are 3 times more likely to have a bowel endometriosis and would require bowel surgery. In addition, obliteration is associated with longer operating time and require the skills of an advanced laparoscopic surgeon. And if we can predict the obliteration preoperatively with ultrasound, this may negate the need for 2 laparoscopies, which means that the first surgery will be performed by a general gynecologist who is unable to dissect the pouch of Douglas or shave a bowel nodule, and the patient will be referred at a later time for another surgeon, which would make the surgery difficult. That could be all avoided if we are doing that assessment. And the second group of implications are reproductive implications. So the following approaches may not be working for that patient. If the patient is trying to get pregnant, it's unlikely that she will get pregnant on her own. And it's unlikely that controlled ovarian stimulation with clomid or letrozole and timed intercourse or with IOI would make a difference, because usually the tubes are either blocked, and even if they are pregnant, they will be buried and geographically separated from the ovary, which will affect the ovum pickup mechanism and the chance of conception. And if you continue to do that, you're going to be wasting time for this patient, which could be very valuable, particularly in patients with advanced reproductive age. We used to say time is money, but in reproduction, we say times is babies. So the realistic option for those patients with complete obliteration of the cul-de-sac, if they are trying to get pregnant and save their reproductive organs, is probably going directly to IVF, or if they cannot afford a careful reconstructive surgery could be performed to improve their chances. This is a patient with complete cul-de-sac obliteration, and that dynamic sliding sign could be done easily by putting the transvaginal probe and pressing in the abdomen and pressing with the probe against the cervix. If it slides, the cul-de-sac is not obliterated, and if it doesn't slide, the cul-de-sac is abnormal or obliterated. So here's how it is done. I have shown this video multiple times before. Pushing into the fundus, it slides beautifully on the colon and then correcting the location and pushing the cervix up, as you can see here. And it also slides pretty beautifully on the colon, which means that the cul-de-sac is not obliterated, as you can see here. So the colon is sliding beautifully on the cervix, as you can see. Is the rectosigmoid involved or not? And we answered this. And is the urinary system, particularly the bladder or the ureter, involved with or not? And we already answered that question in part when it pertains to the bladder. We are left with the kidney and the ureter. And I have to stress, I cannot stress enough how important to do kidney ultrasound in patients with advanced endometriosis. If you see endometrioma, order a kidney ultrasound for this patient. If you can't do it yourself, fine. If you can't, get a formal one. Because I can tell you the patient can lose a whole kidney without even knowing. And unfortunately, I have 3 patients this month alone. 2 of them, all of them have ureteric involvement with hydroureter and hydronephrosis. One of them lost the entire kidney, and we didn't need to operate on her because she's not symptomatic and the kidney is gone. And the other 2, there's still kidney functions that we have to plan their surgery. We couldn't have detected that preoperatively without doing a kidney ultrasound in those patients. This is a massive hydronephrosis in a patient with endometriosis, and this is a patient of mine where the MRI showed an endometrioma encasing the left ureter with hydronephrosis. You could see how big the ureter is in these 2 images. So, ladies and gentlemen, I'm just coming to conclusions here. My first conclusion is that for women with suspicion for endometriosis or pelvic adhesions, a specialized imaging of the posterior compartment can aid in the detection of deep infiltrating lesions and allow appropriate surgical planning and counseling. And it's also appropriate for fertility counseling and treatment choices on those patients, because certain approaches would not work for patients with complete cul-de-sac obliteration, as I have shared with you earlier. And I recommend doing the domain-specific, domain 1, 2, 3, 4, and 5. Transvaginal gel sonovaginography provides additional diagnostic information to conventional pelvic ultrasound, and I think I have shown you enough evidence which would help you plan better. And negative sliding sign is significantly associated with a bout of Douglas obliteration and rectal DIE, and the need for bowel surgery, and can therefore be used to predict complex surgery. And lastly, office gel sonovaginography allows for clearer visualization of the structures of the posterior compartment. And in addition to that, it can estimate the endometriosis fertility index without the need for surgery, and thus save valuable time for patients who are contemplating childbearing. With that, I would like to thank you very much for your attention, and I wish you a very fruitful meeting.